Well, baby, you've been on my mind. I think about you all the time. Oh, I want to see your face. That don't make me wait.
All right, welcome back to Sleeping Around the Podcast with Dr. Ann and Matthew. We are still in beautiful Indianapolis for Sleep 2023. And Ann, you look beautiful. I feel like I'm way underdressed.
Well, I'm a little disappointed you're not wearing a scarf
I know.
or a hat. What's going on here?
Well, and I have a beard now. I don't know if you noticed.
Maybe that's what it is.
It is.
That it's like you need symmetry. So if you had the hat and the beard, it'd be too much. I'd be like, Santa Claus, what's going on?
Hey.
No, I'm just kidding.
Jeez.
I love the beard.
Well, thank you very much.
Don't let my husband hear that though, because I tell him to shave his all the time.
Husband, no. If you guys would be so kind as to like and subscribe, we really appreciate this new direction we're going in, and we are excited. And we have some special guests here. And I don't want to give anything away because Ann's going to introduce them. But I think by the accent, I'm thinking Mississippi, Arkansas?
Yeah, somewhere, I think very close, maybe a state over or so.
Who's our guest today?
So we have Alex and George here. They're from NLS Pharmaceutics. And I'm really excited because, and it's probably going to be a recurring theme on almost every podcast about my passion, central disorders of hypersomnolence, right? They're a company that is very interested in this space. They're developing a product that we hopefully will see become FDA approved at some point. They've had amazing phase 2 data. So that's before we're looking at it in a larger group of patients who have narcolepsy or idiopathic hypersomnia. And they're going to be moving to a phase 3. So this is Alex and George. Can you guys wave to our audience? That's Alex, George.
And as you could tell, again, Alex, say hello.
Hi, guys.
George, say hello.
Hello.
It's Mississippi.
Yes, exactly. Exactly.
Without being too rude, I am actually from Texas. Where are you guys from originally?
I'm from Switzerland.
Switzerland.
But the other half is from Portugal. So my mother is Portuguese, father is Swiss.
Okay. You're a very attractive man. I'm just going to tell you right now. George, go ahead.
I'm originally from Romania. Both halves, yeah.
Okay. And you too are equally attractive. Really appreciate you guys sitting down with us. Anna's been talking about this and so excited, and I just can't wait to jump in. So, Ann, go ahead and let's talk about this because our audience probably doesn't even know what phase 2 even means.
Yeah, so phase 2 studies are really looking at what is the safety profile and is there evidence that there's actually some degree of benefit. And so for you guys, I think you should give us some summary about, 1, what is the disease state you're looking at? 2, what is some of the things that you're seeing with the drug that you're using? And we're going to talk about this particular drug, Mazindol, because it has a very interesting history. And so I really want to dig into what do we know about it from the past, has great safety history, and then what are we learning about it now?
So I think George is probably best positioned. He's an MD. He's my chief medical officer. I'm just the CEO. So he's better positioned to talk about the disease and about the drug. I want to give him the time to shine.
Sounds good. Awesome.
No pressure, George.
Thank you. No. Is it hot here? No, it's not.
It might be. We had to shut off the air. It was too noisy.
Up the air conditioning, exactly. So, listen, it is indeed a very interesting story. So the drug, Mazindol, was actually, it's a drug actually, it's older than I am, to be honest. It was first approved in 1973 in the United States as a weight loss medication.
And at that time, did they have an understanding of how it worked? Like, what was the proposed mechanism as to what was it doing to help people lose weight?
They were thinking it's probably some sort of an amphetamine.
Got it.
But what was intriguing about it was the fact that the drug was a Schedule 4, meaning has very little potential to lead to abuse.
Interesting, which is very different from amphetamine.
Exactly.
So like for our audience who maybe isn't medical, amphetamines, if you were to talk about prescribed class, that would be like your Adderall drugs.
Yep.
And so typically when you're looking at those types of medications, those are controlled substances. They're restricted. You only can get a month at a time. And there's a high addiction potential. So it's interesting that was not the case with Mazindol.
So there was always
have
this
black
question.
box warnings, right?
Yeah,
The C2s, they all have black box warnings.
yeah, the class 2, for example, would have, but we had that. What was intriguing was that it looked like an amphetamine, but didn't really behave like an amphetamine. And there were many questions about what makes it different. However, the interesting thing is that back in the 70s, soon after its launch, some physicians in Europe observed that actually the drug works very well in people who had narcolepsy.
Interesting.
And they started using it off-label at the time, and actually became a mainstay almost of therapy in certain countries, especially in UK and France in particular.
Sure.
Was very much used like that.
And that makes sense because when you look at the history of narcolepsy and the first drugs that were utilized to treat for narcolepsy, it was amphetamines.
Exactly.
And so if I'm a doctor in the 70s and I have a limited repertoire of drugs available and they're going, hey, this is this amphetamine that doesn't have the addiction potential, doesn't have the side effect potential. Yeah, you're going, okay, yeah, I'm going to use it. I mean, the reality is in rare disease state like narcolepsy, you need to use every resource that may be available to you.
And keep in mind, and here the thing is, amphetamine has a very bad connotation in Europe. Okay, it was the drug that Hitler used, that the Nazi soldiers were taking, and so on. So in Europe, amphetamines. That's the reason why amphetamines actually came so late for ADHD treatment in Europe as well.
Interesting.
So I guess that these doctors were looking for another amphetamine or something. So that's when they discovered that Mazindol worked so well. Now the interesting thing is the drug worked so well. That, for example, in France, patients who are failing any treatment, all the treatments available in France for narcolepsy, if you failed everything, the French government was making for you available Mazindol. Okay.
Interesting.
Yes, as a compassionate program, but you had to fail everything.
At the highest dose.
At the highest dose, exactly. So clearly these were treatment-resistant patients. So then you were enrolled into a program in France in which you would receive the drug. However, you had to go through constant safety monitoring and efficacy monitoring. Very
So they were doing their own phase 2, phase 3 studies.
Yeah, exactly. So it's amazing that they've done that, and they collected actually quite a good chunk of data. I mean, some patients were treated up to 14 years, right? 12 to 14 years. The doses actually that they went, actually doctors keep revving them up. They went up to 6 milligrams, for example, which is more than double the dose of the drug that was used for weight loss, and that's interesting that they collected all this data, However, as you probably know, right, in the late 90s, there was this fen-phen scandal about this weight loss, right, in the US, right, with this weight loss supplement that people were taking who induced some heart issues, right?
Sure.
And at that moment, everything came under scrutiny, everything, including Mazindol, like all weight loss drugs, right? Interesting is that no matter how hard they looked, the FDA looked, for example, they could not find any side effects from the cardiovascular that anywhere near to what was seen by fen-phen. So clearly, however, at the same time, the scientific world evolved. At the same time, they realized that you cannot treat really obesity with a pill. There is more in it. You have to have lifestyle changes. You have to have a lot more things.
Yes.
And based on that, pretty much the whole field of weight loss medications cooled off at the time. And
until now, it's reemerged.
It's reemerged, exactly.
With the GLP inhibitors,
Exactly.
I mean, everyone's on it.
Shape,
it's like the big red carpet talk is who's on what drug and
1 shot a week.
Exactly.
And to be honest with you, though, the clinical results for these ones, right, which are studied very different clinical standards nowadays, they're very impressive. For the GLP-1s, let's face it, they are very impressive. Yeah. But the truth is that even those amphetamines back then, they had some effect, but not really for sustained, right? And plus you had to take amphetamine like this.
And so what's interesting is that we recognize that when you're looking at amphetamines, weight loss is a potential adverse event, right? It's something that when we're looking at the clinical trials for whether it's amphetamines or methylphenidates and even wake-promoting agents, you might see it as an adverse event. It generally is occurring in a small percentage of people, right? And so most typically, we're not utilizing them as the primary target to be able to facilitate weight loss. However, with Mazindol, there was weight loss, which starts to then makes you question as to, are the limits of the mechanism really limited to a triple monoamine effect, right? Like, is it really just affecting those areas? Exactly.
Yeah. And that was the question, by the way, all along. They keep coming again and again and again. It's like, is there something else there? And as you will see later in our story, it is something else there.
And I think the part that's interesting when looking at that history is that there's always a question of when you see a reemergence of a drug, why did it go away to begin with, right? So there's always that first skepticism, like it must have done something bad. And the part that's fascinating is it had no safety issues, right? It really was that.
It was a class effect.
Yeah, I mean,
an entire effect of appetite suppressant was affected by the fen-phen scandal, and this was just collateral damage.
Yes.
And by the way, if it helps you with anything, the drug is still available in Japan.
Interesting.
So
Yeah.
40 years is still available there as a weight loss drug,
Yeah.
right?
Yeah.
But
still is available as a
Weight loss
right.
drug,
Yeah.
But the manufacturer at the time and by the way, there are more circumstances here. There were two manufacturers that merged, and when they did that, they saw probably this product should go. So anyway, in early 2000s, the drug disappeared from the U.S. and from Europe. Okay.
Interesting.
For a while, the process that I told you, the study in France continued for a while with some products from Latin
generics,
America,
yeah.
some generics from Latin America. But when those disappeared as well, then the program itself was wrapped up.
Interesting.
So now the story comes, where comes NLS in this? Well, our chief scientific officer, Dr. Eric Conofal, in France, he was using this drug.
Sure.
And then all of a sudden, he has no access to it.
Sure.
And
so he must have been a believer if he's like, I'm
yeah.
using it.
Big
I've
time.
had
Exactly.
a positive experience.
And he was desperate, right? Because he saw how his patients improved.
Yes.
But the drug was no longer available. What do you do,
Yeah.
right? As a physician, because
Sure.
he is still seeing patients on a weekly basis today. So he was looking for a solution for them.
And this frustration led to the decision to found, together with Alex, this company to say, we have to bring it back because it's
Interesting.
such a good drug.
That is, I have to just, the last company that we were just speaking to, right? We were speaking with Natus, and part of what excited me so much about them was they're a patient-driven organization, right? It's about making changes in the life of patients, making it easier, more accessible, better outcomes. What I'm loving, what I'm hearing right now is the same beginnings, right? A physician who is passionate about what he's doing and getting his patients the best care they possibly can, and doing it in means that most physicians don't have the risk taking to even consider.
And I couldn't imagine. I'm a father, and if my daughter was on this medicine, and I went in one time to get it filled, they said it's no longer available, and I know that it works. So again, I really do try to have empathy and go, and I'm anxious to meet Dr. Eric one day, because what conviction, to stand up and say this is what we need to do. And it sounds like an assertive way, not aggressive, not pat, but an assertive way to team up and bring it back.
It's even worse because remember, the patients that were allowed to use Mazindol were refractory to any other treatment, which means the moment this goes, you have no other option.
Yes.
It's not like you can go
That
back
is
to
a
plan
very-
B, C, or
That is
D,
a very, very
right?
good point
So-
to make. And again, I think just as a reminder for our audience, when we're talking about this patient population, it is a patient population who unfortunately is struck by so much stigma because it's such an invisible disease. When you're talking about the
Paint the
condition,
picture for our paint the picture.
So
of what-
patients who have narcolepsy, they look like any one of us sitting here on the couch right now, and you would not be able to say, "Oh yeah, they clearly have narcolepsy." It's not like having a stroke or multiple sclerosis or a seizure disorder where there's a physical manifestation that everyone recognizes, and that
paralysis
it's such a classic kind of, oh yes, that's disability in front of me. For people who have narcolepsy, there's two forms, type 1 and type 2. The most prominent feature is excessive daytime sleepiness, and it's what we say is the most sensitive symptom, meaning that 100% of patients who have narcolepsy have excessive daytime sleepiness. That may mean that they're sleeping longer duration at night. It may mean that they're having naps intruding during the day. It can be a variety of ways. Very frequently, they can be sitting here, we can be having this conversation, and they'll be falling asleep while we're talking to them. And so a lot of times in a society where we're all sleep deprived, sleepiness is looked at as you're just weak.
Yeah.
You just need to
Tough
man
up.
up. I don't care that you didn't get enough sleep. Now, the other features that occur are really representative of the innate sleep state instability, meaning that they can't have a normal night's sleep or day wakefulness like we do. They're having this constant changes. So another feature that is present is disturbed nocturnal sleep. They're waking up very frequently throughout the night. They don't wake up feeling well rested. The other features that we see are generally what we call REM dissociative features. So REM sleep, that's that stage of sleep we all love. It is a stage of sleep where we're having that vivid dreaming. We experience something called sleep paralysis or REM atonia, where we are not able to move. But when we wake up from that stage of sleep, we generally are feeling really refreshed. And the reason is because the neurotransmitters and the brain signaling at the time very much is similar to wakefulness. So the other symptoms people can experience is sleep-related hallucinations. That's that REM vivid dreaming, but I'm awake. So I'm seeing things in my room. I'm hearing people calling my name, trying to break in my door. I'm feeling people touch me. And
So it's like I am in Colorado usually.
But that's for other reasons. And you can also have sleep paralysis, which is what I'm having at Rematonia. I can't move, but I'm awake and I'm aware of it. Unfortunately, many of them experience those two things together. Can you imagine how frightening that is? Being paralyzed and seeing some creepy guy in your room, and never mind. The final is that there can be symptoms of cataplexy. And so this is the part that's frustrating as well, is that when you're talking about cataplexy, the definition already is flawed because it's defined as transient episodes of loss of tone. What does that mean? It means that there can be brief episodes where I experience weakness. The reason I say it's flawed is because in 2011, Dr. Plazzi at Italy had demonstrated that children, as well as those with acute onset of narcolepsy, can have positive motor phenomena. What does that mean? Instead of becoming weak, I have eyebrow raising, I have tongue thrusting, I'm like, eh. Really? These are all features. And we generally will describe it as that it's associated with a strong emotional response. So think about the movie Deuce Bigalow. Yes. Okay? Yep. There's a character in that movie who, it's a horrible media depiction of narcolepsy, where it's a person who looks like they're non-contributory to society. Yeah. They're falling down, they laugh, they're in a complete collapse. That is completely wrong. Right. Most people actually have partial cataplexy. They kind of drop things out of their hands, their knees buckle, they might even get a slight weakness in their mouth where they maybe have slurred speech, sounds like they're temporarily drunk. And when they're sleepy, it enhances that, right? When they have an emotional experience, intense laughter, anger, frustration, it enhances that. In a small population, they may actually experience a generalized event where they collapse to the ground, right? Wow. So when you look at that, that's just describing the pentad symptoms of narcolepsy. These individuals have so much more. Recurrent nightmare disorder, REM behavior disorder, which is a dream enactment feature, automatic behavior. I'm at work trying to do things. I'm pouring coffee on the counter because I'm essentially sleepwalking. That's what it's like. So the level of disability you're talking about, it is a isolating, marginalizing disease.
Now put that person in a manufacturing job, put that person driving, put that person.
Yeah. And now you've removed any treatment option available. So I want to just make sure, as we're telling your story, that it is important for people who are in our audience, because we have a mixture of clinician and non-clinician. And the reality is our vision is people to understand what does this look like? Because there may be people who are listening to this right now and they're going, oh my God, I have every symptom she just described.
100%. Right.
And I've just been told I'm depressed. Yep. Or that it's obstructive sleep apnea.
Or get over it.
Exactly.
Yeah.
And
Stop drinking caffeine after,
Yeah,
whatever.
exactly.
Right.
And so when you're starting to talk about the therapeutic interventions that are available, it's important to really paint the picture of what is the person's experience like? Exactly. Why is an increased number of options such an important thing? Because when you're describing amphetamines as the main treatment stay, that was true for many years. We had amphetamines, methylphenidates, then oxybates came along, and then we had some wake-promoting agents. But we're a field that really, we're now in this really great time frame where there's an explosion of new medications, including Mazindol, that is going to be hopefully available and life-changing for many people.
The other issue I think is important mentioning is that because it's a multi-spectrum disorder,
yes,
right? Most, if not all, of these patients are on a cocktail of drugs, right? So they're taking different medications to address different medical needs, right? We believe that we have indication that with Mazindol, this could be a one-stop shop. We have seen that it actually does treat not only one, but a variety of symptoms.
Sure.
Which was probably another reason why it was so well received in Europe back then, right? Because it was used as a monotherapy. And that's something that we understand by talking to patients and patient associations seems to be a huge unmet medical need.
Yes.
The fact that one tiny little pill half an hour before breakfast will do the job. No need to wake up, no need to redose during the day, no need to mix medications. Maybe not for all, but for many patients.
Yes, and I agree with that in terms of that approach, because the reality is that it's a 24-hour disorder, so they do need polypharmacy very frequently, multiple medications. And so one of the things I always tell my patients is my goal is to create a treatment regimen for you that's going to fit your life, not that your life has to fit the treatment regimen. And so when we're able to simplify that, it makes it safer for them, but we're also then giving them the quality of life that we want.
And y'all know me, I'm going to ask the dumb questions. You guys don't know. I'm going to ask the dumb questions. But isn't there a history of drugs that got launched for one reason and then later relaunched for another reason? I know that there's a pill to have an erection that originally wasn't made for that. It was originally made for something else. So there are histories of launched drugs that weren't necessarily successful, or the mechanism of action ended up finding out it was for something else. I'm sure there's many of those. So this isn't something that's unheard of.
Absolutely not. Okay. Absolutely not. So the fact that it had a history in obesity and weight loss, and now being, maybe there's value somewhere else because of off-label use. Very frequently.
And I'll be honest with you, I see a big advantage in the fact that it's been on the market for decades, right?
Safety.
85% of drugs fail because of safety, right? 85% of the drugs in the research. Well, I'm pretty sure after treating tens of millions probably of people, for decades, safety is not likely to be a big issue here.
Sure.
So that's the big advantage that we see it, right? And as you said earlier, right, amphetamines will not treat cataplexy, right?
Sure.
Here's a drug that has this potential, and that's the beauty of it. So you have safety on one side, well demonstrated over decades, and now we have data from a phase 2 study to show actually that it works beautifully both on the sleepiness component and on the cataplexy.
So let's unpack that a little bit. So phase 2 study, these are generally smaller studies, and we're really looking to see what the signal is, not only in the safety, but also are you making meaningful changes in the things that matter to the patient? So the excessive daytime sleepiness, the cataplexy, those typically for drugs and narcolepsy are the main targets we're looking at. Right. And so I think an additional piece is my understanding, even when we're comparing what current Mazindol is compared to prior, it also has a different kind of duration of effect, right? So that was a more short acting, and this is more of a kind of extended release formulation. Is that correct?
For weight loss, it was 3 times a day. Yeah. While now this new formulation that we developed makes it to be a single once a day. In the morning, it's a tiny little pill, 6 millimeters, the tablet that you take. And hopefully then for the rest of the day, you put narcolepsy to sleep.
And it's important because, when you because it has wake-promoting properties, right, Mazindol, right? When you dose it 3 times in the day, maybe the last one in the afternoon, due to its half-life, it's going to impact. One of the most important features that we have not seen in our phase 2 data is insomnia as a side effect. Yes. Virtually every narcolepsy drug in its clinical data has insomnia. Mazindol doesn't have it. Why? Yeah. Because you take it before breakfast. You're awake, you're in a state of wakefulness actually, and alertness during the day, which is important, right? Because you want to drive, you want to be able to maneuver machines. And then towards bedtime, right? Because it fades out, it will actually induce sleepiness. So it's perfect, right? It will let you sleep, where some of the drugs that are currently on the market will impair that.
Sure. No, that's
so
definitely a struggle.
The dosing is important, and the fact that we came up with this technology that will allow you to dose it early in the morning and then forget about it, right? Is very important. Whereas the original Mazindol, which was an immediate release, you had to dose it several times, and they had insomnia with the original Mazindol.
Sure. So let's unpack the phase 2 data. So what was the experience that you guys had? So do you have patient experience of how they were reporting to maybe their sites, or obviously you're going to tell us about what the overall data looked like. Right. But I think some of the things, what kind of patient were you looking for to enroll in this? Was this your narcolepsy type 1, type 2?
Was there an age range? Was there female, male? Was there a specific?
So who was invited to
We
play?
were very open. So women, men were all accepted into the study. You had to be 18 and above, because the scales that you use are usually made for adults. But other than that, we're pretty open. Now, of course, there were a few things that we were worried at the time. We're thinking, is there drug-drug interaction, for example? If you take a drug or enzymes in the liver that process other drugs, for example, if you inhibit those and you alter those drugs, that can be a side effect, right? And as you know, many of the current medications have this issue, right? That they induce inhibition or induce enzymes in the liver that consume faster or slower other drugs that patients take, right? So that's why that was indeed something that we limited. But otherwise, you had to have...
and when you say you limited it, what you mean by that is patients weren't allowed to be on other medications that would interact.
That were very sensitive, exactly.
So these are patients who are kind of similar to Eric's population. They didn't have any other options. They had to be taken off their other options. Yeah.
Correct.
So patients who were essentially untreated, who had narcolepsy, either type 1 or type 2. Main distinction there being that individuals with type 2 don't have cataplexy. There's also the kind of biochemical component that we know in narcolepsy type 1, individuals have a deficiency of a specific neurotransmitter called orexin. And we can do a spinal tap and we can measure that and we can show that. And if you were to have a person with narcolepsy type 2 and if you were to do a spinal tap, they would have normal levels. And so both of these types of patients were eligible for enrollment.
We had
Yes.
two features in this study, right? Correct me if I'm wrong, George, that I think were unique. And you correct me if I'm wrong as well. The first one was it was only a 4-week study. I'm not familiar with other narcolepsy drugs looking at the 4-week duration. That was the first one.
It's usually
Usually it's
longer.
8 to 12 weeks, right? Usually 8 weeks. And the second one is it was used as a monotherapy, right? So you had to wash out of any pure medication. You were not allowed to be on any narcolepsy background medication while being on Mazindol. Not only in the double blind, but we had a second study, which was a longer time safety follow-up study for 6 months, where basically patients were up to 7 months on no other drugs.
Yeah.
And I think the two features were what makes this phase 2 unique, in my opinion.
Yeah. And I'll comment on that for a week because clinically, when you're seeing a person, I always try to educate other physicians on what is the anticipatory guidance that you need to give a patient when you prescribe a medication? What do you need to prepare them for? Because every patient has the same question. When do I expect to get better?
Right.
I want to be better today, right?
Right.
And so most typically, a lot of the medications we prescribe, we tell them you'll probably see the peak benefit in 8 to 12 weeks. Which is why most of the designs of the studies are that long. Now, what's also challenging when you're talking about people participating in trials like this is that it depends on the study design, but there very frequently can be something called a randomized control trial, meaning like somebody might get drugs, somebody might get placebo. And when you have 8, 12 weeks where you can't be on anything at all and you have a debilitating disease,
And you're on placebo.
And you're on placebo.
Yeah, and the sugar
That's what I
pills,
was
it's
thinking,
totally-
exactly.
yeah, that makes it hard for people to want to participate.
Exactly. And the beauty of it is just as you pointed out, is that these results have shown us that actually from the week 1, when it's the first time we measured it week 1, already the drug is doing significantly better. So that separates statistically, right, between drug and placebo. So those who took sugar pills were doing clearly worse than those who took actually
first
Mazindol from the first week. So this is a very powerful signal that we think we've seen. Now, and we've seen this not only on the sleepiness part, but also on the cataplexy part. So the drug treats both symptoms. Now, of course, there were fewer narcolepsy type 1 patients because that's how they are out there. There are not as many as narcolepsy type 2, which meant that we had fewer patients. But even with those fewer narcolepsy type 1 patients, you could see the cataplexy improving already from week 1 and continuing to improve throughout the study, the 4-week study. So that was indeed, from our perspective, it kind of confirmed what we knew from the clinical practice, got us very excited about it to see how quickly you have this type of efficacy.
So we're going to have all this benefit. There has to come with some baggage. So what is the adverse event profile? Because very frequently, I think everyone laughs at the commercials we see about drugs, right? It's like, it's going to change your life. Yeah, exactly. And you may die. And so
Well,
how many
like-
deaths? How many? No.
It's kind of like my life. The package is great, but there's a lot of side effects. 2 ex-wives. We start there. Alphabetical, chronological. But no, please, is there something that to be aware of?
Yeah, of course. I mean, there is no perfect drug, right? Water can be toxic after all.
100%.
Right?
100%.
So it's
That's why I don't drink it, just strictly vodka.
I'm a big believer in
Great,
that.
don't you?
No, but joking aside, so clearly there are adverse events, right? That we have seen more with the drug than with placebo. That's why we have sugar pills, right? To see people sometimes experience things just because they live, right,
Yes,
out there. And some
100%.
things happen, right? That's why you need a placebo arm. So what we have seen indeed with the drug higher than on placebo is dry mouth.
Okay.
We have seen this in up to 20%.
Sure.
Of
Very
patients.
common in most of the drugs that we utilize.
Very
right?
common in any sleep treatment,
Yes.
whether a CPAP,
Yeah.
an oral device,
Yeah.
dry mouth.
Right.
Exactly.
It's so
Think
that's-
about clonidine. Use it for like off-label for sleep, and that's
yep.
like the worst side effect that people.
Lunesta was this big thing that was happening in the early 2000s to help people sleep.
Yeah.
Dry mouth was the
Yeah.
number one. So that seems to be a common thing.
Yeah, that seems to be, and this is the most prevalent we've had. Okay, so it was 20% of patients versus 3% on placebo.
Yeah.
Okay.
So you can see there's dry mouth on placebo as well.
Right.
Sure.
Then it was nausea at 9%.
Okay. Can I ask a question real quick? I noticed that you said take it at breakfast after food. Is that
Before
something-
breakfast. Maybe that's why.
Okay.
Yeah. Because obviously if you would be with food,
Yep.
it would be better,
Yep.
right? From a nausea
Because we're
standpoint,
coding the
of
5
course.
HC.
Yeah,
and,
exactly.
And again, I think we have, I'm pretty sure if and when this drug is going to be launched, people are going to try it with food, because if it was on the market for 30 years, you can imagine not everybody was taking it
Especially
without
if it
food.
was for a weight
right?
loss
Yeah.
drug. I mean,
Yeah.
that's the problem, right? So one of the things that I want to know, because the biggest challenge that I have with patients who have narcolepsy or idiopathic hypersomnia is they are already more susceptible to mental health issues. Every single drug that I prescribe, one of the big anticipatory guidance piece is talking about this may increase your risk for anxiety, depression, suicidality.
warning.
Exactly. And that's the part that's a real challenge is because there is that psychiatric comorbidity that can exist, but we also see that we can bring it on with a lot of treatments. So tell me about the mental health profile. Were you seeing that there is anxiety, depression, suicidality, things like that?
I'll let George discuss on that. I'm pretty sure about his answer, but I'll quickly quote something from an ADHD study because years back we also tested the drug in ADHD. And one thing that really astonished me was like people saying the beehive, the brain fog was gone.
Interesting.
ADHD patients, right? So I think in countries like instead of actually inducing
And this
anxiety,
was in pediatrics ADHD.
no, it was this
Adult?
was an adult US also 85 patients across the US,
And
very
excellent
successful
results,
phase 2
excellent
trial,
results, yeah.
excellent results at par with amphetamine in terms of ADHD rating scale reduction.
Interesting.
Amazing, really amazing.
Interesting.
Same safety profile, 20% dry mouth, but there I remember because I was there that the beehive and the brain fog is gone. For the first time in my life, patients saying I was able to actually do a checklist in my brain, right?
Interesting.
Not having to write it down.
Yeah.
So
Yeah, that's a real problem because I'm a checklist person. You come into my office, it looks like a beautiful mind. I have whiteboards all over because I need to have checklists everywhere.
I'm watching a Dateline episode or something.
You can join our next study then.
Yeah, there you go. There you go. If you do another adult ADHD study, sign me up.
But I know you said you wanted him to comment on it. Is that okay?
So what about the anxiety and the other?
So yeah, the interesting thing, we did not see irritability, we did not see anxiety, we did not see suicidal. We even have the scale, right? Columbia suicidality scale
Sure.
to look for that. Like it's normal in CNS drugs, right? We did not see any of these. Now,
That's
of course,
great.
keep in mind it's a 67 patient study.
Sure.
Okay.
I mean, this is the reason why you're going to go on and you're going to
into
do further
phase 3
studies,
when
right?
you look at more patients.
So have you
Exactly.
guys gotten FDA guidance on being able, so the FDA, obviously, they're our big body that says, what can drugs do? What can drug companies do? Can I get approval? So what have they weighed in? They look at your phase 2 data. They're like, they're interested, not interested. There's going to be something else coming down the pipe.
They seem to be very interested. Actually, it was a very good meeting that we had with the FDA. They had, of course, guidance, which I think was very useful. They have this big advantage that they see behind the scenes of all the other drugs, right?
Yes.
And they apply learnings from the others.
Yeah.
It's so interesting.
It's
to
like
see
the Wizard
when
of
they,
Oz.
exactly. And they suggest things, and you realize, like, how
Behind
did
the
they
green
know
curtain.
that? Because you go and you look at your data. You know, they made a suggestion. Maybe you should look at your data this way. And it's like, how did they know that? We went and looked at the data, and indeed, it does look better. So clearly, they
They
have
have
this.
like the cheat sheet.
Exactly,
I got it.
exactly.
You're like,
They-
why? How do we hire you?
But they will never tell you what they know. But clearly, they come up with these things, and it's very, very interesting how they look almost like.
So they do have a purpose. I'm just kidding. So it sounds like they were excited. They gave you green light
to go to the phase 3,
so
which will
phase
start
3.
very
so
soon.
who are we looking at for phase 3? Who in our audience should be listening to this and going, I need to find a site? Who can be in a phase 3 study?
Narcolepsy type 1 patients,
Okay.
first and foremost.
Okay.
We think the biggest need is in patients with cataplexy, and
Okay.
that's what we're going to focus our attention on.
Okay.
Our hope is that once we are on the market and we'll be able to, right, we're a very small company, just
Sure.
to put you in context, we're less than 15 people,
Yeah.
functioning from Switzerland,
Yeah.
quite far away from here. So money is an issue for us, I'll be honest. So then clearly, once we get on the market with the narcolepsy type 1, then we'll be looking at other things beyond that, narcolepsy type 2, IH,
What
and
I
so on.
think is a good thing, and this is the teaching I always give to my medical students and my residents, et cetera, when they're asking me for career advice, is that everyone's always worried about where the money is, right? So I'm specifically making this comment, is that follow your passion, the money will follow, right?
Correct.
Your company that clearly is based on passion. You have Eric at the helm, who he wanted to bring this back, resurrect it, not only resurrect what was the old, but create it anew and really study it in significant detail. And so you guys have done additional study. Outside of the phase 2 study, you alluded to this several times of that, you know what, this drug is doing something that the mechanism that we're saying it is doesn't make much sense. So I know you guys have had some great data that you shared during sleep. So tell me about how some of this additional study may inform a little bit more knowledge around how this drug might even be.
And how, when this is being viewed, how can our audience find you guys?
Right.
Whether that be a website or they can find this data that they're going to be presenting, correct? At Sleep 2023. We're here right now. Dan, I'm doing good. Time continuum. So whenever we do release this, that they'll be able to go back and probably view
Right.
that. Okay.
So it's going to be on website. So go ahead.
No, I think before we go there, obviously you can we'll give you the name of the website that you can go and register or get more information. But what Anne alluded to is that the root cause of narcolepsy is believed to be, at least for type 1 patients, the loss of a neuroprotein in your hypothalamus called orexin, right?
Yes.
That's widely accepted and about 25 years ago discovered at Stanford, if I'm not mistaken. But so far, nobody has been able to bring a drug to the market that kind of slows down the loss of the orexin, right, in the brain. And so obviously the entire space is very much interested on this orexin angle.
Oh yeah, there's
right?
probably about 15 different drug companies right now trying to develop
Try to bring-
agonist.
There's a race.
Try to bring the first one to the market, right?
Yeah.
When
It's like the space race. Who gets to the moon first?
That's why we're in Indianapolis. With Eric, when we did the ADHD trial, and again, we saw things that were surprising, right? He went back and said, I need to understand this mechanism of action better.
Sure.
I have to search broader. And so he found a very initial signal on the orexin receptor 2.
Interesting.
A binding signal. And he then said, well, this kind of explains why,
Sure.
weight loss, because appetite regulation is linked to your
Yeah,
orexin
which is
system,
why it's
right?
even called orexin,
why
right?
it makes sense, right? So he looked deeper, and since we're a small company, we cannot put all our efforts on preclinical or basic research, right? We are in clinical research, but nevertheless, because the interest is so big on the orexin angle, we are doing constant in vitro and in vivo studies, try to understand the mechanism of action better. And what we have found so far is that there seems to be a partial signal on the orexin, right? Whether it's mediated or direct, we don't know yet at this point. But there seems to be something happening with the orexin system, maybe in a less direct, less selective way than maybe with some of the other drugs that have been developed that have some other issues that we are not seeing with our compound, for example, hepatic toxicity.
Sure.
Right.
Matt, you getting all this?
I am.
You understand?
No, I'm so far so
Okay,
good.
okay.
I know Mississippi well.
Okay, good.
So the orexin angle is what really is actually driving the entire space, and we believe maybe in 5 or 10 years from now, there's going to be the market's going to look different. You're going to have
100%.
you're going to have drugs that actually try to slow down or maybe even reverse, right? The orexin death.
Sure.
And
So we're
and
looking at,
bit
instead of
like-
symptom management, potentially getting to the root cause. And
Exactly.
I think when you
Exactly.
talk to patients, that is something that they're all very interested in. And I think you allude to something that's really important, which is that we do have a pretty strong comfort of that orexin loss is what drives narcolepsy type 1. Type 2, we still don't really fully understand. My personal belief is that it's probably still the same pathway. It's just not, it's not lost. It's dysfunctionally signaled. And so therefore we may see benefit, but it may be different dosing that we're going to be utilizing.
I mean, it's interesting. And that actually, if you look, our drug worked very well in both NT1, narcolepsy type 1, and in narcolepsy type 2, right? So it's very interesting. Why I think, we know that there are like 5 neurotransmitters, right, involved in narcolepsy, right? Serotonin, norepinephrine, dopamine, histamine, and orexin, of course, right? So all these 5. What we find interesting is that this drug touches upon 4 of the 5. Okay, so it's not something that's extremely narrow on one, but actually is on several pathways. Now, of course, right now there are drugs which are being designed to hit specifically orexin, right? And they can be very effective at touching upon orexin. Our drug, Mazindol, is not one of those drugs. We just discovered by chance. I mean, we're going to make that disclaimer. This was not designed by us. We just discovered that it works on orexin. Maybe not as targeted, as strong as the drugs that are being made right now in the race. But keep in mind, what we have comparing to those drugs, we have 40 years of safety.
Yeah.
Right.
Yeah.
Those
I think that speaks a million different ways. So for me, when I just think about what is the kind of clinical setting of our doctors thinking about mechanism action, our patients thinking about mechanism action, not typically, right? The main thing is saying what's going to interact with one another, and am I going to tolerate it?
Yeah.
And I think having
Can I stay on it? Is
Yeah.
it going to help me? Am I gonna-
Exactly. And so at the end of the day, whether it's a debate about a rexinergic mechanism of action or not, data is data. And so if I have safety data, that is a big driver. Patients want to know that I'm not going to experience all these horrible things. And so that's beneficial. The phase 3 that you guys are going to do is going to only add on to the data you have to be able to better inform how are we positioning this medication. And I agree with you that when we look at all the different treatment options, there's different targets involved, and it's not necessarily for everyone, but it becomes more relevant to more people if more people can tolerate it. So I can make the best drug that it is, but if no one can tolerate it,
Exactly.
then I've done a
we call
disservice.
it the well-rounded drug. That's how we call it.
And
Right?
that was my nickname in college, by the way. On that note, I thought there was some really good coincidence because we need to wrap up. I really do appreciate you gentlemen's time. I really do. Thank you for coming on our podcast. So this drug, and I want to make sure it came to America in 1973. Did I hear that right?
Yes.
As did I in 1973.
Perfect timing.
I just felt like that was something I needed to share.
It's almost like
So
a brother
it's a
to you.
really old drug.
It's a really and just like me, you took my line.
No, I'm telling you, my husband would shoot me because he was born also in 1973.
It's a great year.
It's
So
a
it's a
great
good
year.
It's a great
Clearly
year, yeah.
produced a lot of really good people.
But I'm, Anna's been talking about you guys with me for a while and just so excited. And that I actually got to sit in on this one, probably just throwing a little jokes in there, but I'm fascinated with this. And for you guys to take the time today to come and share with our audience, and just really appreciate it.
And they'll be able to check you guys out on NLS Pharmaceutics website. And they also can always go to clinicaltrials.gov to be able
Correct.
to see any
They
of the
will
clinical
see-
trials, what sites are available.
We'll give you the link to do the.
Yeah, we can give you the link to our website where they can go and find their closest
Absolutely.
site.
And on our YouTube, we'll have it right down there. So people can scroll down right now, actually, and go down there and you click on the link. Guys, thank you so much for sleeping around with Dr. Aaron and Matthew. Really appreciate it.
Thank you very much for having us.
Thank you. Thank you, Matthew.
you.
Bye.